Hello, everyone. Through the years, we are getting more and more sick patients because of multiple comorbidities, and so the potential for clinical deterioration is much higher than in the past. Perhaps the most valuable indicator of deterioration is a high index of clinical suspicion. Oftentimes, we diligently do our charts without either recognizing patient deterioration or having appropriate interventions to patient deterioration. This is the outline of my talk. Why we need to recognize early on patient deterioration, why we fail to recognize deterioration, who are at risk, clues to deterioration, rapid response systems we need to adopt, and practical approaches to patient deterioration. Let me start with this message. Patients do not suddenly deteriorate. It is us who suddenly notice. In the majority of cases, deterioration is gradual in onset and is associated with the development of abnormal vital signs. Good doctors not only anticipate a complication, but also recognize it promptly and accurately. What I'm trying to imply here is that early recognition is the key to preventing devastating complications. A not so uncommon example would be a case of unrecognized esophageal intubation of a patient for STAT CS wherein direct laryngoscopy was difficult. The ET was passed over the bougie, mechanical ventilation was commenced, but the capnograph remained flat. The resident felt certain that the ET was correctly inserted and wrongly concluded that the capnograph must be malfunctioning. Desaturation was noted and hypoxia ensued despite increasing FiO2 and minute ventilation. Later on, laryngoscopy done by the consultant revealed an esophageal intubation. Clearly, in this case, if esophageal intubation was recognized earlier, hypoxic brain injury could have been prevented. A crash is never a good thing, whether it happens to an airplane or to a patient in the operating room. The practice of anesthesia and flying an airplane shares some key characteristics, namely team communication, continuous monitoring and vigilance, and SOPs, or in our case, clinical practice guidelines. The airline industry has taken huge steps in enhancing safety by adopting and implementing CRMs or cockpit resource management or crew resource management in the 1980s, and this has dramatically improved airline safety. Much like flying an airplane, to prevent a patient from crashing, we need to capture the error or recognize deterioration early before it progresses and causes an adverse event. In anesthesia, we have CRMs also, or Crisis Resource Management, and these safety procedures were adopted from the airline industry. The US National Transportation Safety Board discovered that the common thread of more than 50 fatal aircraft accidents is very simple. Lives were lost that could have easily been spared. It is very important that we learn from this as well. Earlier, I mentioned that patients do not suddenly deteriorate. Usually, the situation does not turn from normal to suddenly abnormal, but oftentimes normal, then somewhat normal, I think, then abnormal. We have to learn to recognize the somewhat normal finding and act on it to prevent more serious events. Adverse events are rarely caused by a single factor and typically occur when a number of conditions are met. According to Rampersad and Rampersad, adverse events often occur along the following trajectory of adversity. First, there is a catalyst event like a desaturation, followed by a system fault like failure of the pulse ox alarm to alert the anesthesiologist. Next is loss of situational awareness, and an example would be the anesthesiologist is preoccupied with the paperwork and does not recognize the desaturation. And lastly, human error like the lack of continuous monitoring by the anesthesiologist. This is a dynamic error model from Captain Rampersad, a US Airways Airbus pilot, and Dr. Rampersad, an anesthesiologist. The ball represents an adverse event or an abnormal finding. Any one of the four barriers or peaks, namely technology, clinical practice guidelines, proficiency, and judgment, can prevent the ball from rolling down the hill. At any time, the ball can be stopped by recognition and resolution of the abnormal finding by one of the four barriers. So really, recognition of deterioration early on is very important to avoid morbidity and mortality. There are two reasons patients deteriorate. First, some deteriorate despite adequate clinical care. Second, patients deteriorate because of inadequate care. When do we say that there's inadequate care? Inadequate care is described as lack of awareness, which may be loss of situational awareness as mentioned earlier, lack of awareness of clinical practice guidelines or safe practices, lack of training, poor proficiency and poor judgment, and human error however minor it may be. In the UK, the NCAPOD identified that the prime causes of patients becoming acutely unwell are delayed recognition and inappropriate therapy. They also found out that ICU admission could have been avoided in 21% of cases. In 2007, NICE published a document entitled Acutely Ill Patients in Hospital, Recognition of and Response to Acute Illness in Adults in Hospital, and they concluded that patients who became unwell received inadequate care, and this may be because their deterioration is not recognized, is not appreciated, or is not acted upon sufficiently rapidly. In 2004, the academia study found that 60% of primary events like deaths, cardiac arrests, unplanned ICU admissions were preceded by documented abnormal physiology, the most common being hypotension and a fall in GCS. The Between the Flag system is a safety net for patients who are cared for in New South Wales, Australia public hospitals and healthcare facilities. It is designed to protect patients from deteriorating unnoticed and to ensure they receive appropriate care if they do. Between the Flags acknowledges that early recognition of deterioration can reduce harm to patients, and the earlier the better. The slippery slope diagram shows how the Between the Flags system is designed to intervene in the process of patient deterioration with two key interventions, namely clinical review and rapid response. The logic of the slippery slope compels one to not only try to develop safety nets like Between the Flags, but to develop systems that prevent patients from going down the slippery slope in the first place. We now know why early recognition is important and the reasons why we fail to recognize deterioration. Let us now identify who is at risk of deterioration. Clinical deterioration can occur at any stage of a patient's illness. However, they are most vulnerable during the onset of their illness, during surgery, and after discharge from the ICU. Studies have demonstrated that the elderly, those with high ASA scores, congestive heart failure, and emergency surgeries are associated with an increased risk of deterioration. In a large database of more than 2,400 patients undergoing major general and vascular surgery, the rate of unplanned intubation due to deterioration was 2.6%, and the presence of renal failure and significant COPD were predictive factors. Using the American College of Surgeons National Surgical Quality Improvement Program data, consisting of more than 200,000 patients, Hua and colleagues found that the factors most associated with unplanned intubations are more than 80 years old, high ASA score, presence of pre-op sepsis, and total operative time of more than 6 hours. The following are subtle warning, often non-specific signs, which suggest impending problems. I will briefly discuss some common ones in the next slides. Failure to respond to fluids may indicate a pump problem, and actually, giving more fluids will produce more problems. On the other hand, in some cases like in trauma or sepsis, they may need some more fluids. Increasing oxygen requirements may be due to the patient's oxygen extraction is abnormally high, either due to anemia or a low cardiac output. Increasing ventilator pressures would mean either a decrease in lung compliance or an airway obstruction. Examples are bronchoconstriction, pneumothorax, congestion, or a simple mucus plug. Hypothermia may not only be due to the cold air conditioning, but may be due to a low cardiac output or a vasoconstricted patient. Acidemia and/or increasing lactate levels signify hypoperfusion, which may be due to a low cardiac output or low BP, anemia, or sepsis. Traditionally, decreasing urine output signifies low perfusion states. It is imperative, however, to first rule out a kinked or disconnected catheter. Tachycardia should always be a warning sign. In fact, the first commandment in the strategy for preventing ischemic events is to avoid tachycardia. Remember that tachycardia reduces the time for coronary perfusion, especially in patients with pre-existing coronary disease. I cannot overemphasize the importance of early recognition of deterioration because of the established association between an abnormal vital sign and an adverse outcome. In a study that included almost 900 patients aged 60 years or older undergoing vascular surgery, a 40% decrease from the pre-induction map with a cumulative duration of more than 30 minutes was associated with post-op myocardial injury. In another study that included more than 5,000 patients undergoing non-cardiac surgery, AKI occurred in 6.3% of patients and was associated with MAP less than 60 mm mercury for 11 to 20 minutes and MAP less than 55 mm mercury for more than 10 minutes in a graded fashion. These studies again imply that deterioration is not so much sudden, but rather suddenly recognized. In the early 1990s, hospital deaths after adverse events and post-op complications were described as failure to rescue. Rescuing failure to rescue patients requires early recognition of deterioration, complications, and adverse events, and second, systems to rapidly respond to such crises. The rapid response system is a concept based on the early recognition of instability and systems to rapidly respond to perceived abnormal physiology, such as abnormal vital signs or a sudden change in vital signs. Identification of pre-arrest physiology can help identify clinical deterioration minutes to hours before a serious adverse event. Studies have shown that more than 60% of cardiac arrests were avoidable. This is actually why rapid response systems really make sense. This is the medical emergency team calling criteria. This is the type of rapid response system they use in Australia. It uses a single parameter triggering a response from a specific team. This is the rapid response system called NEWS, or National Early Warning Score. This is the system we are trying to adopt at St. Luke's. The NEWS is an aggregate scoring system used predominantly in the UK, and it is calculated by assessing the RR, oxygen saturation, whether or not the patient is needing supplemental oxygen, temperature, BP, heart rate, and level of consciousness. This is the new score threshold and triggers. Note that if there's a red score or a score of 3 in a single parameter, it automatically becomes a medium risk. Note also that this chart must be reproduced in color and should not be modified or amended. This is the new score outline for recommended frequency of monitoring and clinical response. This is a slide from Team Steps from the Agency for Healthcare Research and Quality in the US. This data from Australia shows that the medical emergency team works. Again, these numbers show that rapid response systems work. They decrease arrests and deaths as well as ICU transfers. How do we approach an abnormal vital sign? A strategy promoted by Dr. Wood involves asking questions about the patient's circulation. The first question asks whether the cardiac output is too high or too low, and this will split the diagnosis into high and low cardiac output shock states. The second asks whether the patient is too full or too empty. Fluid resuscitation is frequently a solution to intra-op shock, but there are times when resuscitation might be harmful. The final question addresses what doesn't fit. Another practical approach to deterioration is to start with the circulation. Although cardiac arrests are mostly related to non-cardiac causes, cardiac instability is always the final common pathway. Another suggestion is to ask for the origin of instability, namely the pump or the contractility, pipes or the vasomotor tone, preload or the intravascular volume, voltage or arrhythmia issues, vessels or the coronaries, and valve dysfunctions. If the answer to the previous questions are no, then you can assess the other organ systems, whether the pulmonary system, neurologic, metabolic, or maybe toxins. In conclusion, the concept of rapid response systems, specifically early recognition of physiologic instability, whether it be an abnormal vital sign or a sudden change in vital sign or a biochemical abnormality, applied in our practice inside and outside of the operating room, can save lives. With that, I am happy to answer any questions that you may have.